interests were found. So today I'll be presenting one of our sub-interns from several months ago, Adam Nolte. So he hasn't been a face on round for the last several weeks, but you'll remember him, I'm sure, quite fondly. He did a good job back in June. He's also a Yale medical student, and so he's kind of been in the wings for the last several years. I'm sure many of you have interacted with him, and he's been a charming addition to the team. He actually made quite an impact, I think. He was a very intelligent sub-I, was always well read, and was caring to his patients. I think he did an excellent job from our perspective. But a little bit more about him. So as I said, he's a fourth-year medical student here at Yale, and his original rotation was back in June. He's originally from New Jersey, and he did his undergraduate training at Duke University, where he majored in biomedical engineering with a focus in medical imaging physics. Just very interesting. During his free time, that's going away soon, don't worry, Adam. He enjoys playing lots of sports. He plays tennis at the club level as an undergraduate, and he's heavily involved in intramural soccer and basketball teams here at Yale. He's also a writer and director for the Yale medical films, and he's working on writing and directing his class's fourth-year show. So once again, Adam Nolte.
Thank you. Hello, everyone. Thanks for having me back. So today I'm going to be discussing renal cell carcinoma and end-stage renal disease. I'm going to be going into tumor characteristics as well as screening and treatment. This is work I've been putting together as part of my thesis with Dr. Shuck, as well as a collaboration with Dr. Humphrey in pathology and with Dr. Formica in the renal side of medicine. So I have no financial disclosures. And I'm just going to begin by talking about 3 cases, just by way of introduction. This is just sort of to set the stage for the rest of the discussion. These are all cases that I've been reviewing as part of my research, and whenever I look at these cases, I like to think about how these patients are being screened as well as what treatment choices are being made. So our first case is a 62-year-old female. She was on peritoneal dialysis for over 10 years and presented actually with signs and symptoms of bacterial peritonitis, where she had a CT scan as part of the workup that revealed bilateral renal cysts and a 2.8 centimeter left-sided cystic renal mass. In the middle, we have a 65-year-old gentleman who actually had a living relative kidney transplant back in 2011. And since that transplant, at the time of that transplant, was found to have cystic kidney disease, and so he was being followed with screening MRIs. About a year and a half after the transplant, he was identified to have a 1.5 centimeter enhancing renal mass. And then finally, our third patient is a 67-year-old gentleman who had a deceased donor kidney transplant back in 2004, and he actually was found as part of a workup for graft failure to have a 2.5 centimeter renal mass within the graft kidney itself. So these cases sort of illustrate the spectrum of cancer that can be present in these end-stage renal disease patients, and just a good framework to keep in mind as we continue the discussion. So for an outline for today's talk, I'm going to begin by talking about end-stage renal disease and the risk for developing RCC in both dialysis and transplant patients. I'm then going to move on to discuss tumor characteristics and RCC prognosis, and finally we'll finish with a brief description on both how the literature and patients from our research inform both screening and treatment. So first, just to set the stage, the end-stage renal disease population is a large one in the United States. There's over 660,000 dialysis patients with about 18,000 kidney transplants performed per year. And you can see here, this is data from the Scientific Registry of Transplant Patients. And you can see that the number of patients listed for transplant had been steadily increasing to about 100,000, whereas the number of kidney transplants themselves performed has been pretty stable at around 18,000 per year. You can see the most common indications are diabetes and hypertension in the United States for the need for transplant. So moving on to how dialysis puts these patients at risk. So patients are at risk for what's called acquired cystic kidney disease. This is an entity first described in dialysis patients in the late 1970s, but actual descriptions in the literature date back to the mid-1800s. So 22% of these patients are actually not on dialysis. So while dialysis is a significant risk factor for developing these acquired cysts, it's not the only way patients get that. And that's because it's thought that dialysis, essentially these patients develop these cysts because they're in a uremic state. And what dialysis is doing is actually extending the amount of time those patients are in uremia. And I'll get to this a little bit later, but it's thought that transplants can potentially be somewhat protective by providing more of a steady state filtration and decreasing the amount of uremia the body's exposed to. And then finally, we know that ACKD patients are at higher risk for RCC, and I'll get into that a little bit later. But it should be noted that not all cases of RCC within these dialysis patients are related to ACKD, with 17%, or as much as 17% of them being from other factors. So it's not the only way these patients get disease. So this is the study I alluded to on the previous slide coming out of the late 70s. And it's a group out of Oxford where they actually did an autopsy study where they looked at the kidneys of 30 deceased patients from their institution. And essentially what they did was they just looked at the kidneys themselves, and found that 14 of their 30 patients actually had bilateral cystic disease, and 6 of those 14 presented with tumors, 5 of which had multiple tumors. So you can see here in the picture that these cysts can invade the entire kidney parenchyma. They actually describe cysts ranging from being just on the surface and subcapsular to invading the entire parenchyma itself. And here's an example of a histological slide from their paper where you can see they described a papillary type tumor with tumor cells coming out of the epithelium lining one of these cysts. So I mentioned earlier that these patients are at higher risk for developing cancer, and this is a paper out of the mid-90s that actually reviewed the incidence of cancer in both ACKD patients and patients in the general population. You can see here that they found that the incidence in ACKD patients is much higher at 0.18% per year compared to a general population of just 0.005%. So this is true for dialysis patients, but what about patients in the transplant group? So this paper comes out of Italy by this group, Falcamo and others, and they actually looked at an observational cohort study where they took 694 patients at their institution. They ended up taking out about 90 of those patients because they had either had bilateral nephrectomies or were placed back on hemodialysis. And what they were essentially looking at is the incidence of RCC, comparing these patients that had pre-existing acquired cystic kidney disease versus those that didn't. You can see that among transplant recipients, those with pre-existing acquired cystic disease had much higher RCC incidence compared to the non-ACKD counterparts. So that sort of sets the stage, and now I just want to briefly talk about the tumor characteristics and overall prognosis for this group. So in discussing tumor characteristics, it's important to think about what the general population is. So this is actually data from Dr. Shuck, and what he had done in this paper was essentially looked at how well the SEER database correlates with independent pathologic review of the specimens in that database. And I'm presenting the data here just so to illustrate that for national samples, the rate of papillary tumors tends to be about 16 to 17%, whereas clear cells up in the mid-70s. If we go ahead and compare that to patients in the end-stage renal disease population, this data comes out of Japan by this group led by Dr. Hashimoto. You can see here that they had almost 1,800 patients with RCC, 408 of which were on dialysis, and they studied this over 34 years at their institution. You can see from their table 1 here that they noted that the papillary tumors were way more common at 22% versus just 5% in their general population. So as part of my thesis work, I've been looking at sort of as many of these case studies as I can find, and I'm putting together some tables. So we can see here's 9 case series that present similar type patients. I highlighted the one out of Japan because it had the most cases. But you can see here that for all of these cases, the papillary histology tends to be higher than that we would expect in the general population. And if you look at these papers individually, for the most part, it tends to be that their papillary histology was more dominant in comparison to their general population for those that actually gave that data. So we know this is true about dialysis patients, but what about patients on the transplant side of things? So the largest study in transplant patients comes by Dr. Karamani and others. This paper is out of Bethesda. And then what they did was they looked at the transplant center match study with the large database and identified over 116,000 patients who had undergone kidney transplants. Of those, 683 were found to have renal cell carcinomas. And they found that this was an increased risk of 5.7 times the general population, and as well noted that papillary histology was again the dominant finding. So if we go ahead like I did for the dialysis patients and chart out some of the other reviews that have been done for those in the transplant group, we can see once again that papillary histology is the predominant feature in these patients. For allograft tumors, these are kidney transplant recipients that are developing cancers in their renal transplant itself. One of the larger reviews I could identify comes from this group, Troxel and others out in Stanford, where they identified 11 patients at their institution that developed these tumors, 6 of which had papillary and 4 of which had clear cell. As part of their paper, they presented data on other institutions, and they noted that there was 44% showing papillary overall. So I think I've made it pretty clear that dialysis, transplant, and transplant in the native kidney and the allograft kidney all are at higher risk for developing papillary tumors. So what does that actually say about these patients' prognosis? So these tumors do tend to be less aggressive. This data comes out of Japan, where there's this single institution reviewed 44 of their cases among over 2,600 dialysis patients. And you can see that for the most part, we're talking about lower grade tumors and lower stage tumors. It should be noted that, especially in Japan, I'll get to this a little bit later when I talk about screening, Japan tends to have more aggressive screening protocols, so these patients are potentially being detected earlier in their disease state than they would be here in the United States. So moving on to transplant patients, this paper by Brita and others actually does a good job of looking at both pre and post transplant patients and comparing them to their general population. You can see once again that stage of disease for the non-ESRD patients tends to be much higher. You can see in their population, 51% of the non-ESRD patients are presenting at stage greater than PT2, whereas much lower percentages of patients are beyond stage PT1 for both pre and post-transplant. And once again, you can see that papillary histology tends to be more common in these patients. So we know that these patients have lower stage and lower grade tumors. Does that actually translate into a better prognosis? So this same group actually looked at cancer-specific survival for both the clear cell and papillary type histologies. And they noted that the end-stage renal disease patients, these patients with less overall aggressive tumors, had statistically significant better outcomes in terms of cancer-specific survival. So before I move on to screening and to treatment, I just wanted to briefly touch on some other lingering questions. The first is that, is this idea of renal transplant being protective for RCC actually valid? So one paper that I looked at by this group, Schwartz and others out in Germany, actually attempted to describe the percentage of ACKD patients within the kidney transplant population as opposed to the dialysis group, and found that these patients were less likely to have ACKD overall, and hinted that that might be that the transplants are protective. In terms of actual evidence of this, it's pretty limited, but there is this paper from the early 80s that actually did demonstrate some involution of kidney cysts on CT scans in the same patient, both pre and post-transplant. So another way to get at this question would be to look at how long, among transplant patients, how long, did the effect of how long they were on dialysis pre-transplant actually translate into different outcomes? So the paper I had mentioned earlier in the talk by Phil Combo and others actually did just this. And you can see here that patients who are on dialysis for longer periods of time actually have much higher RCC incidence compared to those on dialysis for shorter periods of time. So it's an open question in terms of whether these patients are actually having less or improvement in their renal cystic disease versus the idea of just getting a transplant early on as actually just giving them less overall exposure to dialysis itself. In terms of histology, just a brief note about that. There's also an entity that I haven't really been focusing too much on called clear cell papillary RCC of end-stage kidneys. This was described back in the early 2000s by Dr. Taku, and this is a paper that kind of presented a commentary on that entity. And I liked it because I feel like this picture does a very good job of demonstrating both the papillary and clear cell type architecture in these tumors. And here are just some representative examples of a low and high mag papillary tumor compared to clear cell tumor. And again, clear cell and papillary tumors from some of the more pathologic reviews that I looked at. So what does the data here at Yale have to say about this? So far, Dr. Shuck and I have reviewed 7 dialysis cases and 12 transplant cases that have presented here within the last 5 years. And we looked at so some of the things we looked at are histology, and we're once again noting that papillary histology does tend to be more common, although for the dialysis group, papillary histology is way more common in comparison to our transplant patients. And once again, we're noting that the stage and presentation of these tumors does tend to be at lower stage. However, we did note that there was 4 cases of metastatic disease, all of which presented in our transplant patients. So another thing that I've been looking into is actually plotting out how long it takes these patients to develop tumors. So this is a chart I created among the Yale patients where we have the dialysis patients' time to get RCC versus the transplant patients. And so something I'm interested in is why these transplant patients might be doing better than the dialysis patients. And as I hinted at, it could be because the transplant is somewhat protective. But the thing we have to keep in mind is it's difficult for us on the chart review to discern how long these transplant patients were exposed to dialysis. And for example, some of these patients that have 20+ years post-transplant developing cancers are actually, one of them is a patient with Alport syndrome who had his transplant in his 20s and never really had any dialysis exposure. So we're gonna have to do a little bit more work to parse out those patients from this in order to understand any differences between these 2 groups. So moving on to the back half of the talk, I'm gonna briefly touch on how both our literature and examples from our research inform both screening and treatment. So for screening, it's important when you're developing a screening paradigm to think about which patients would benefit the most from screening. So these are 2 national database studies that looked at what the largest risk factors are for both dialysis and transplant patients to develop RCC. So this first group comes out of Medicare ESRD data, and you can see here that patients who are male, patients who present at older age, as well as some forms of kidney disease, including tuberous sclerosis being the highest risk factor, patients are more likely to develop these tumors, as well as patients with acquired cysts. And I've kind of hinted at earlier that this acquired cystic kidney disease is one of the most predominant risk factors. For the transplant groups, things like diabetes and hypertension tend to be significant risk factors, as well as increased exposure to dialysis overall. So this idea of kidney cysts and increased exposure is pretty intuitive for reasons why things like diabetes or hypertension may be driving more tumor development. I will be working with some of the renal nephrologists to come up with some hypothesis for why that could be. Something that comes to mind is perhaps these patients are doing worse overall in terms of response to dialysis or response to their kidney and end up with a higher grade of being in a uremic state. And that could potentially lead to increased rate of tumors. So in terms of screening, as I mentioned earlier, Japan actually has done a little bit more in work in screening than we have here in the United States. And this is data coming out from the early 2000s that followed 848 patients, 7 of which were detected by symptoms and a majority of which were on those screening protocols. You can see here that they actually showed a significant survival benefit for patients on dialysis who are being routinely screened for development of tumors, and this is both for overall and cancer-specific survival. In terms of data from the United States, I could really only identify one paper that actually built a simulation model for the introduction of either an ultrasound or CT screening protocol. The model itself included things like significant comorbidities in this population, as well as the risk for surgical complications. And you can see here in their 3 sort of output figures. The first shows intuitively that patients who are not screened are more likely to die from cancer, but they're also less likely to have surgical complications and deaths from surgical complications. And if we look at the overall net benefit, they noted that they really only thought there would be a benefit for patients younger than 50 in this population. So in terms of reasons why the group in Japan and here in the United States might be very different, one thing to keep in mind is that although these patients are all on dialysis, their disease is actually very different in nature. So here is data nationally in the United States, noting that in the United States, a majority of our dialysis and transplant patients are diabetes and hypertension patients, and that's also true of our group here at Yale. But if we look at some of the papers that have come out of Japan, almost all of these have disease that's isolated to the kidney. So these patients do tend to be less sick overall in terms of the United States having diseases that are more systemic in nature. So in terms of screening the transplant group specifically, this population overall tends to be less sick in terms of their renal function because they're able to have that steady state filtration. And the population overall, as I've hinted at, it might be at decreased risk of having these acquired cysts overall. So in terms of recommendations, one paper by Dr. Sikanamala and others actually recommended screening for ACKD at the time of transplant and then following that up with, if they are noted to have cysts, with serial imaging in the post-transplant setting. In terms of the guidelines, the Kidney Disease Improving Global Outcomes Group advises against routine screening because they feel like it leads to unnecessary treatments, whereas the European Association of Urology group recommends annual screening in both native and graft kidneys. So in terms of our patients here at Yale, sort of how, when I review these charts, I kind of like to think about how they were managed and if that management could have been improved. So of our 12 kidney transplant patients, 4 of them ended up having been on a screening protocol similar to that described in the previous slide. 3 of those presented with small renal masses, and 1 of them with a 6.2 centimeter lesion. All of these patients were able to have success, or 3 of them were able to have successful nephrectomy, and 1 was managed successfully, is currently on active surveillance. So of note, we had 4 cases in this kidney transplant group that were metastatic in nature, so it is possible that we could be detecting some of these tumors early enough to actually intervene, especially in patients that we know happen to have pre-existing acquired cystic disease and are at much higher risk for developing these tumors. In terms of the dialysis patients, there's no patients here at Yale that were undergoing routine screening under the dialysis, but 3 of the 7 actually had tumors detected upon workup for transplant. All of these were able to have successful nephrectomies, and 2 of them went on to have successful transplants, while 1 of them remains on the transplant list. So at the end of this, I'm kind of getting at treatment, and I'm going to go into more details about treatment for the last part of the discussion. So treatment options in RCC obviously range from, in terms of invasiveness, from nephrectomy to active surveillance, and then there's also this question of systemic therapy for use in patients with metastatic disease. So when you're going to do a nephrectomy in these patients, it's important to think about, is this actually a safe and effective operation for patients who are on dialysis? And this group, Keen and others, attempted to answer this question by comparing both laparoscopic nephrectomies done in their general population and comparing it to the ESRD population. So here I'm highlighting the Clavian grade outcomes for both groups. And you can see, although they didn't reach statistical significance, there was some indication that there was higher risk for the end-stage renal disease in terms of complications compared to the non-end-stage renal patients. So potentially more data would need to be collected on this to see if this is or to get more power to see if this is actually a true relationship. Another way of answering this question comes out of another paper from Japan, in which they looked at 174 patients on hemodialysis. And here they're comparing the patients who are on dialysis for longer periods of time to the patients who are on dialysis for shorter periods of time. You can see the patients who are on for longer periods, greater than 5 years versus shorter than 5 years, actually did have worse overall outcomes. But they concluded that they thought the operation was still safe to proceed in both groups. And most of these outcomes tend to be because these patients are overall more sick than the patients who are on dialysis for fewer years. In terms of other treatment options, nephron-sparing surgery has very limited utility in this population, as they already have a non-functioning kidney, so you're not really sparing anything. You can potentially think about it in a patient who's an otherwise non-operative candidate for a more invasive procedure, although there's no literature describing that that I could find. In terms of active surveillance, there's again limited literature. It's theoretically a good population to choose active surveillance because they have low-grade tumors that tend to be detected very early on, and they potentially have higher operative risk. But active malignancy can also be a contraindication to doing a transplant. So these patients might have to have the native kidney come out anyway in preparation for getting their transplant. So what about in transplant patients? So in terms of actual papers that talked about the overall success of these operations, one paper that I found mentioned that none of the patients in their cohort needed to suspend their immunosuppressive agents, and none of them needed additional dialysis. Among our patients here at Yale, we noted that 6 of the 8 patients that we identified with non-metastatic disease had successful nephrectomies, whereas 2 were managed with active surveillance. Finally, moving on to the allograft tumors. Allograft tumors or kidney or cancers preventing them, you have to treat it like a cancer presenting in a patient with a solitary kidney. So for tumors that tend to be indolent and growing slowly, actually removing the kidney itself might be more harmful in terms of overall quality of life and mortality than doing an active surveillance protocol. Things like partial nephrectomy and ablation can be considered in these patients as well. However, you don't want to risk pushing the patient over to dialysis because they have very limited renal reserve. So in terms of what the literature has to say about this, I found 2 case series by Swords and others and Sue and others, and these essentially looked at each 4 patients. And they noted that patients at their institutions were successfully treated with a range of options, including nephrectomies, partial nephrectomies, and ablations. So really what this comes down to is picking the best option for your individual patient based on their overall renal reserve, as well as what the operative or where the kidney sits and what operative approach would be most ideal. In terms of our patients here at Yale, we noted that of the 3 patients that developed tumors in their allograft, 1 was managed on active surveillance, 1 had a nephrectomy. This was a patient with PT3 disease and a much larger tumor, and 1 actually had metastatic disease and was put on systemic agents. So that brings me into the last part of the talk, which is the management of metastatic disease. So this is data out of Italy for TKIs in dialysis patients. And there's some thought that TKIs are potentially nephrotoxic and they should be limited in patients with underlying kidney disease. So these are very limited case series that looked at both 24 and 36 patients and found differing results in terms of whether these drugs actually had increased toxicity in their populations. So for now, there haven't been any trials in this population. And so expert recommendations say that while these drugs are not contraindicated, they potentially have this increased risk for nephrotoxicity. So you should consider what the overall kidney function is of your patients before proceeding. In terms of the transplant patients, Klatt and others provided some commentary on this, where they looked at both TKIs and mTOR agents. And they said that they overall have limited overall efficacy, but no randomized trials have been evaluated. In terms of data that they actually presented on this, they did a review of 28 transplant recipients back in 2009, but they really only indicated 1 patient who was put on systemic therapy, and they never commented on how that patient did overall or whether there were any adverse events. For immunotherapy, again, this also hasn't really been studied. There's a risk for taking an immunocompromised patient and ramping up their immune system for increasing rejection. In terms of whether these drugs have actually been used, the only real examples I could find were some case reports of IL-2 being used, but those actually required suspension of the immunotherapy regimen. So for the cases I've reviewed so far here at Yale, we've had 1 patient treated with sunitinib, 1 with everolimus, and we actually had 1 patient who was having some graft failure. So in the chart, they noted that they didn't want to start a TKI because of the risk for nephrotoxicity. And then we also had 1 patient who actually died of unrelated causes and was not able to start a systemic regimen. So kind of revisiting the 3 cases that I mentioned in the beginning of the talk, we can see here that these are pretty good representations of the types of patients I've been describing. So here we have this 62-year-old woman who was on dialysis for 10 years, found to have renal cysts and a small renal mass. Again, we have a patient who received a kidney transplant, was being followed for known kidney cysts and found to have a renal mass. And finally, a patient that received a kidney transplant and was found to have a tumor in the graft kidney. So in terms of how these patients did, the first 2 had successful nephrectomies and, as expected, were found to have low-stage, low-grade papillary tumors. Our 3rd patient actually had a biopsy that revealed papillary histology, and was, because of the graft failure, was chosen to be managed on active surveillance as they didn't want to risk doing any further damage to the patient's kidney reserve. The patient continued for about 1.5 years, but eventually needed to be put back on dialysis. So now there's a question of whether or not we should go ahead and remove that non-functioning kidney since it harbors a renal mass. So in conclusion, we know that RCC is of higher incidence in these patients, and that is true for both dialysis and transplant groups. The majority of these cases present at early stage with papillary histology. Screening has unclear overall benefit, but it appears that patients who are young and on dialysis, or those who have known acquired cystic kidney disease and have received a transplant, are most likely to benefit. In terms of treatment, radical nephrectomy is almost always the best option, but active surveillance is appropriate. And this is especially true for patients who have already received a transplant, who are not being needed to be listed beyond the transplant list. And for those with metastatic disease, there haven't really been any trials indicating for safety and efficacy in this population. And that's all I have, and I'd like to open up the floor for any questions. Yeah. So are you getting at the idea that patients who are on immunosuppressant, potentially oncogenic viruses and other entities can increase the risk? Yeah.
And the regimen of anti-rejection medication, it isn't really same as doing immunotherapy for cancer. So I should not be so silly to think, well, just overall suppression can be worse cancer. The question is, what is the contribution? How do you factor that out? I just want to add a second point.
Yeah.
The second is, I think your comment about screening is interesting because, you said they're either symptomatic or what are the symptoms of ACKD? I can't think of a real symptom, but most of these people might have
Yeah.
Hematuria, which is not a symptom. And then you get into the question, are they truly screened? Because screening implies intent or lack of intent. Most of the people, like I see a lot of them that recurrent UTIs, get some imaging to look at sources of, oh, we found this complex. That's not really screening.
Yeah.
I would say it's more of an incidental finding. And then how do you sort through the lack of symptoms and the intent of those are my two thoughts.
No, absolutely. So in terms of your first question for the effect of being on immunosuppression and whether that increases cancer risk, I think I actually have a slide. Let me see. So basically, my understanding is that these patients overall, like the kidney transplant population as a whole, is at increased risk for cancers of all types. And whether or not that has, 2 to 3 times higher risk for developing cancer. For RCC, the risk does appear to be higher. So whether or not that's the cystic disease on top of their immunosuppression that's driving that, I think hasn't really been parsed out, but it's a very good thought because patients who are immunosuppressed are more likely to potentially develop cancers. In terms of the screening question, from what I can see, the data in Japan, those patients do have ultrasounds done every 6 months, and they're more on a screening regimen. For symptoms, I didn't really look specifically at what symptoms they were talking about, but my guess is it might be more likely more symptoms of having more advanced disease, in which case that's why those patients are doing much worse because they're presenting much later. Dr. Kenny?
That was a really great talk.
Thank you.
Great. You mentioned the papillary histology is more common. Is there a predominance of papillary type 1 or type 2, or is that not the one?
From what I've found in terms of the examples here at Yale, I actually haven't seen any papillary type 2s. I've seen a couple papillary type 1s. Most of these papers actually just say papillary. I'm actually working with Dr. Humphrey in pathology. We're going to review all the slides from Yale and see if we can identify any other morphological features that might be interesting.
Issue that comes up in a lot of patients, surgically for localized cancer, disease. When is it safe to have people on the transplant? Has anyone written anything about for the patients who are on hemodialysis or treated for renal cell? Has anyone written anything about time when it's safe to test on transplant?
As far as I could tell, there's not like a specific guideline. It's just like they say like these patients are or shouldn't be listed for transplant until they have no more active malignancy. But it's an interesting question because these tumors tend to be also lower grade and present very early on. So would they actually be spreading? And what you might be able to do a transplant earlier in these patients than other forms of malignancy. So I think it's an interesting point. Not that I looked at it in my review, but it's an interesting question for me to go back and think about for sure. Dr. Lehman and Dr. Singh.
I have a couple of patients who had small renal masses who were very small, had other comorbidities, but were still listable for the transplant. And I've communicated with the transplant team extensively about these 2 patients. It might be the ones that you had on your slide. And they actually listed them. So they're actually on the transplant list because their conclusion, I guess, not only in discussions here at Yale, but with UNOS people, were that if that's how the patient would normally be managed, independent of their renal failure and transplantability, then that's how they can still be managed currently. So they are listed. I don't know if they've gotten their transplant or not. The other thing is I can't remember. I've done a bunch of nephrectomies on transplant people. I can't remember the last time there was one that had a very large concerning mass. They all tend to be these really small little tumors. So I think in and you kind of said that in your very nice comprehensive discussion. But I think one of the things that goes into it that I didn't see is that not only are these tumors small, but the average life expectancy of someone who's on dialysis, which is about 5 and up to 10 years. So when you talk about screening on someone who's on dialysis, it's very likely they have these small renal masses. They're going to die from something other than one of these small renal masses.
But I wonder if it's, worth noting that these patients are not formally screened, but de facto they are, right? These are heavily medicalized patients. That's when I was wondering, in the case series here,
Yeah.
what was the reason that these patients, these tumors were identified? We've acknowledged that they're small, incidental masses, so presumably they're incidental. So they're undergo cross-sectional imaging or an ultrasound, as maybe graft failure or something.
Yeah, so as I mentioned, there was like a couple patients that actually were identified on ultrasound as part of transplant workup versus screening for their known cystic disease. But then there was a bunch of, like, one of the patients I had an example of was a patient who has bacterial peritonitis who has a CT scan that is found to have a kidney tumor. And then there's a bunch of other examples of patients who have had some other type of infectious symptoms and they undergo a CT scan. So they're definitely, a lot of them are incidental findings. And if you go back and look at the radiology for these patients, they have tons of imaging studies that you can sort of trace these tumors' development over time. One thing that I found interesting was that the transplant patients themselves, a lot of times have screening ultrasound just for their transplant kidney, but not in their native kidneys. And I was kind of confused by that because they're already having an ultrasound procedure. And if we just looked at those native kidneys, some of these patients, we could actually be identifying tumors, and it wouldn't actually be any more additional cost for them if they're already sort of in the ultrasound room at that point.
We have seen some interesting behavior. Recently, Dr. Kohlberg had a patient who had a drop metastasis from a clear cell RCC from a native kidney into her bladder.
Yeah, that's one. I've actually read that. Yeah.
So interesting. I mean, the role of immunosuppression is a strange thing, and I think we're learning more about the growing HIV positive community. The NIH is prioritizing studying secondary cancers that are probably immunosuppression related. So, like you said, Dr. Chai, the immune system is pretty complex and kind of a black box.
It's also kind of a provocative hypothesis generating finding about the fact that there's a high rate of papillary tumors, because one of the standard questions that patients ask is, "Doctor, why did I get this tumor?" Of course, we don't know unless they're clear identifiable carcinogens like smoking, but almost always, we believe, the answer is going to come down to some genetics. Whether we can identify it or not at this time, we don't know. It's usually not one gene, an interplay of many different genes and protein products, but usually there's some genetic predisposition for someone to get a cancer. But then if someone who's on dialysis then has higher rates of papillary, then it sort of breaks that thought process.
Yeah.
And maybe there's some other identifiable or yet to be identified carcinogen that's in play.
Yeah, and I'll just mention that Dr. Humphrey in pathology right now, they're actually taking 5 of these end-stage renal tumors and sequencing them. So they're going to actually attempt to at least find some data on whether there's a genetic component to this disease. Yeah, for pretty much every study I looked at, there's papillary predominance, but not all of them necessarily compare to their general population. So it's kind of hard to say there's like 28% papillary in Japan, and then I know there's something percent papillary here in the United States. But the ones that actually looked at, like I presented the one paper that actually compared their 2 groups, did have statistical significance for papillary predominance. Thank you.